Good evening, respected colleagues, friends. First of all, I thank Dr. Prathapan and his learning in general surgery for giving me this opportunity to talk on anatomy of liver, hilum, and biliary tract, a surgeon's view. So, in the liver and biliary tract surgery, you have to obey certain basic tenets. You have to remove all the pathologically involved tissues, but you have to preserve the maximal amount of functioning non-pathological liver tissue. And you have to perform safe resection while ensuring adequate blood supply to the remaining hepatic parenchyma. So the knowledge of anatomy is very important for a biliary and liver surgeon. So the most consistent feature of biliary anatomy is its inconsistency. So that is the first and very important point I have to mention. So the normal anatomy you can see in only 57% and variation is the rule. And at the liver hilum, biliary system and arteries shows maximum variation and portal vein the least, because developmentally portal vein develops first and the arterial system develops last. And nowadays we have plenty of imaging tools. We have increasing experience in liver transplantation, giving donor liver transplantation. So we are better in defining the variations in the hepatic hilum. So coming to the history of biliary surgery, this is Carl Johann August Langenbuch, who did the first cholecystectomy. We consider cholecystectomy as a very simple operation, but the cholecystectomy evolved through a various complicated surgical procedures. So if you know the history of cholecystectomy, the first cholecystectomy was done very late in 1870, 1880 or all. But before that, people did surgery for empyema, creating a fistula between abdominal wall and taking out all the stones. The gallbladder as an accessory organ rather than very important organ are understood very late. So people were thinking about preserving gallbladder in the initial stages. Now there are some surgeons in China, they are doing the same stuff which they did in the earlier part by taking stones only from the gallbladder, but keeping the gallbladder intact. So the popular incision we put for cholecystectomy is known as the Cocker's subcostal incision, because Theodore Cocker done the first successful cholecystostomy in 1878. And later, Langenbuch developed the technique of cholecystectomy by identification of cystic artery, cystic duct, and division and removal of gallbladder. But later, the cholecystectomy was done by many persons. But the next history in the surgery of gallbladder comes when the laparoscope was introduced. So there are controversies in literature. But when I found a galloscope, which was done first by Eric Mew in Germany, he did the first lap chole internationally. And Philip Murray, almost at the same time, he did the first lap chole. That was shown in earlier literature. But when you confirm, it is Eric Mew who did the first lap chole. So coming back to the development of biliary apparatus develops from the foregut. So liver and biliary tract are foregut in origin, whereas pancreas is partly foregut and partly hindgut in origin. That is why the variation in blood supply of liver and biliary tract. So from the embryonic foregut, by fourth week, a diverticulum form. That is known as hepatic diverticulum. The caudal portion gives rise to the gallbladder and cystic duct and the CBD, and the cranial portion gives rise to the intrahepatic and hilar bile duct. Endothelium and blood vessels of the liver actually develop from mesenchyme of septum transversa, and endodermal cells differentiate into cords of hepatic cells and epithelial lining of intrahepatic bile duct. And finally, once the rotation is complete, the duodenum is rotated, the bile duct comes to a retroduodenal position. So there are many anatomical variations described in gallbladder, like absence of gallbladder, multiple gallbladder, bilobed gallbladder, double cystic duct, left-sided gallbladder, and intrahepatic gallbladder. These are all clinically significant when there is a symptom of cholecystitis, and when you imagine the abdomen for abdominal pain, you may find absence of gallbladder. It may be due to agenesis, or it may be to location difference of gallbladder, or it may be purely intrahepatic gallbladder. There are some congenital disorders of biliary tract like biliary atresia and choledochal malformation like choledochal cyst, which I am not going into the detail. But a few words about biliary atresia. It's an obliterative disorder affecting both intra and extrahepatic part of biliary tree. And it is first described in 1891 by John Thomson. And late in 1960, Morio Kasai developed the surgical procedure, popularly known as portoenterostomy or the Kasai's procedure. And first liver transplantation was done for biliary atresia by the Thomas Starzl in 1963. And biliary atresia can occur as an isolated event or as a part of malformation syndrome, like Eye-Mark syndrome. So classification, you have type 1, 2, and type 3. Among these, type 3 is the commonest, where in type 1 you have proximal CHD and gallbladder intact. So it is easy to do surgery. Type 2, you can have the access to the hepatic duct, but in type 3, if you dissect the porta hepatis, you will not find any bile duct. So they have opened that area and performed what is known as the portoenterostomy. The second malformation is known as the choledochal cyst. This is the classification by Chodani et al. You have 1 to 5. And this is basically due to an abnormality in pancreatic duct and bile duct junction. So the type 1 and type 4A choledochal cysts are seen in association with abnormal pancreatic duct bile duct junction. There is a high incidence of carcinoma, gallbladder, and bile duct in these patients. And these patients will have abundance of pancreatic tissue around the head of pancreas, around the bile duct. So this may be due to delayed recanalization of bile duct or persistence of the ventral pancreatic duct, which I discussed in my talk on anatomy earlier. So sometimes you can see abnormal pancreatic duct junction, bile duct junction without dilatation of the bile duct. But the anomaly is a risk factor for malignancy of the biliary tree, including carcinoma, gallbladder, and carcinoma of the bile duct. So this is the classification by Japanese Society on Pancreatic Duct Maljunction. So you have type A, what is called a stenotic type. Type B, you have non-stenotic type of common channel. Type 3, you have dilated channel, and type D is the complex type. So gallbladder is a pear-shaped organ located on the visceral surface of liver. It is popularly known by Italians as fossa vesica fella, and it is separated by liver by the Glisson's capsule. So Glisson's capsule will not cover the gallbladder, it covers only the liver, and that separates gallbladder from the liver. And it may be varying in size, length, etc. But usually it has a capacity of 30 to 50 ml, and it can increase up to 300 to 500 ml when there is biliary obstruction or when there is obstruction of the cystic dead-forming mucosa. So you can see a very large gallbladder in patients with the mucosal. Before rupture, it can collect up to 500 ml. So it is composed of a fundus, body, and neck. The narrow part of the body with its junction to the neck is known as the infundibulum. So fundus is the blind ending projection of gallbladder, which is seen below the liver edge. And body is the largest part of gallbladder, and it is related to the first and second part of duodenum and transverse colon. The infundibulum is the angulated posterior portion of the body between the neck and point of entry into the cystic point of entry of the cystic artery. So when you train the students to do the cholecystectomy, the infundibulum is given more importance rather than the cystic duct bile duct junction. This is to avoid injury to the bile duct. So there are some deformities described in gallbladder like Phrygian cap deformity, that is the folding of the fundus on its own, seen in around 2 to 6%. Sometimes stones may lodge in the folded gallbladder, and that may be creating problem. Hartmann's pouch is not a congenital thing. It is not a developmental thing. It is an acquired thing due to lodging of stones or inflammation. And it is seen secondary to an impacted stone in the infundibulum. So after the gallbladder, you have the cystic duct. It has a diameter of 3 millimeter and a size of around 2 to 4 centimeter. The size can vary, and it joins the CHD to form the CBD. So the length of CPD varies, length of CHD varies depending upon the entry of cystic duct into the common hepatic duct. If there is no entry of gallbladder, cystic duct into the bile duct, like a long cystic duct entering the lower part of bile duct, you will see only common hepatic duct, no common bile duct. So the cystic duct is provided with 5 to 12 oblique folds known as the spiral valve of Hister or sphincter of Lütgens. And the junction of cystic duct and the bile duct varies. It can be an angular union in around 75%, parallel union in around 20%, and spiral union in 5%. I have put a picture of different union, and sometimes the cystic duct will form a sheath along with the bile duct, and sometimes it may actually very difficult to remove this part during cholecystectomy, and you may leave a long stump of cystic duct that may produce symptoms. And an angular union of cystic duct actually creates a problem during cholecystectomy that can actually injure the common bile duct or common hepatic duct. So coming to the blood supply, the cystic artery usually arises from the right hepatic artery, and it can arise from other sources as well. It courses usually superior to the cystic duct, and at the superior aspect of neck of gallbladder, the cystic artery usually divides into two branches. One is a superficial branch and other is a deeper branch. And the deep branch is seen as the branch between the gallbladder and liver. That is the main branch of cystic artery. You may see another branch which is the superficial branch. So this is the variation in origin of cystic artery. It is usually arising from right hepatic, but it can arise from other arteries, including the gastroduodenal artery or sometimes the left hepatic artery. So the venous drainage of gallbladder, I will come back to it in detail when I discuss the bile duct. So venous drainage of gallbladder is very important regarding the management of carcinoma gallbladder is concerned. But when you do cholecystectomy, usually we see only cystic artery and cystic duct. We won't consider cystic vein as an entity during cholecystectomy. But there are veins which connects the gallbladder either directly into the segmental veins or the portal veins, or it may be joining some plexuses in the hilum, and finally it is getting connected to the portal vein system. So when imaging is done, sometimes you may see lesions around the gallbladder fossa. This is known as the pseudo lesions. So when you see hepatic pseudo lesions, this may be due to the abnormality in the venous drainage of gallbladder or the area of the gallbladder fossa. So gallbladder vein or the cholecystic veins are many rather than a single one. And these branches around the GB fossa, or it may actually join the parabiliary venous plexus at the porta hepatis. And this parabiliary venous plexus is distributed to the segments which are adjacent to the hilum, like segment 4 and 5. So when there is a carcinoma of gallbladder, it can directly invade the segments, or it can invade secondary by invasion of these veins. And the same communication is responsible for development of hepatic pseudolesion. If you open the abdomen or do laparoscopy, you won't see anything. But if you imagine in the using CT or other contrast imaging, you may see some lesions in that area. The lymphatic drainage of gallbladder is very important because the most important predictor of survival in carcinoma gallbladder is the involvement of lymph nodes. So there are many lymphatic pathways described in relation to the gallbladder. The fundus and proximal part of body has less lymphatic pathway, lymphatic system, but the neck of gallbladder has plenty of lymphatics, and they form 5 groups of lymphatics, and they communicate with the hepatoduodenal lymphatics, and finally form trunks like right lymphatic group and trunk anterior lymphatic group, then internal lymphatic group, so many groups which are not very important for students. But The three main lymphatic pathways which take lymph from the gallbladder to the lymph node is important. One is the cholecysto-retropancreatic pathway. Second is the cholecysto-celiac pathway, and a minor pathway known as cholecysto-mesenteric pathway. So these are the pathways which takes lymph from the gallbladder into finally into the inter-aortocaval lymph node. So all these are interconnected, and these are the three groups described earlier. And these are the dissection specimen of the lymph node groups and the lymphatics described. And there is a very important lymph node described that is known as the node of hiatus, lymph node of hiatus. Actually, that lymph node of hiatus is situated between the junction of D1 and D2, where the bile duct crosses the duodenum. And that lymph node is the most important lymph node which carries lymph from the gallbladder. And this is the second group of lymphatics which takes lymph into the celiac group of lymph nodes. After the anatomy of gallbladder, there are some important things which are very important for the students. One thing is known as the duct of Luschka. We may say duct of Luschka is seen, this is responsible for the bile leak in the post-cholecystectomy system, but it is not very common to see duct of Luschka. I will show a video where I have seen a duct of Luschka in a patient in whom I did a Whipple's procedure recently. So I did a fundus first cholecystectomy and there was bile leak. So I identified a duct which is connected to the duct of segment 5, and I probed into that duct, and that was actually going into the bile duct of that segment. So there was a duct which is connected, but that is not directly draining into the gallbladder. So the duct of Luschka usually will not drain into the gallbladder. It will be in the subvesical plane only. So the duct of Luschka is the second most common reason for post-lab chole bile leak, and a better terminology is a subvesical bile duct. And there are 4 subtypes based upon the anatomical characteristics described. One is the segmental or sectoral subvesical duct. Type 2 is the accessory subvesical duct. Type 3 is a hepatico-cholecystic bile duct. That is the one which I was demonstrating now. And there is a type 4, it's the aberrant subvesical bile duct. Among these, the type 2, that is the accessory subvesical bile duct, is most common. When you do cholecystectomy, during the dissection of gallbladder from the gallbladder fossa, if your dissection goes deeper into the liver parenchyma, sometimes you may injure this bile duct. But the management of leak from a duct of Luschka is just to observe or do some drainage. But if there is a communication with a segmental duct, you have to do ERCP and stenting. Then the second issue is the landmarks during cholecystectomy. So these landmarks actually help in safe cholecystectomy, and it avoids injury to CBD, CHD, and hepatic artery. This may include triangles like Callot's triangle or Callot triangle of cholecystectomy, or known as the hepatocystic triangle, and it also includes a sulcus known as the Rubius sulcus. There is a 3-line, 1-plane concept that is actually described in patients undergoing lab CBD exploration for safe exploration of CBD without injuring to the segmental duct. So this is the Callot's triangle, but we commonly use the term hepatocystic triangle. Actually, the Callot's triangle is a content of hepatocystic triangle. So the original content of Callot's triangle is only the lymph node, because the boundary of Callot's triangle is cystic artery, cystic duct, and common hepatic duct. Whereas the boundary of hepatocystic triangle is the lower border of liver, the cystic duct, and the common hepatic. The Rubius sulcus is described by Henri Rouvier in 1924. He was a French anatomist. So during laparoscopic cholecystectomy, identification of Rubius sulcus is very important. Never go very close to this sulcus. So it is a 2 to 5 centimeter sulcus running to the right of liver hilum. It usually contains the right portal pedicle or its branches. The cystic duct and cystic artery usually lies or invariably lies anterior to and superior to the sulcus. Always keep the dissection above the sulcus. And this Rubius sulcus may contain the anterior sectoral duct or it may contain the posterior sectoral. We can't predict just by looking at the external view which pedicle is inside the ruveus sulcus. Usually it is the posterior pedicle seen inside the deep to the ruveus sulcus. So there are various types of ruveus sulcus described. Like one is a scar type where there is not much of exploring of the bile duct. Then there is a slit, like the proximal part is not seen, it is covered by parenchyma, or the distal part will form a slit. Or it can be a closed type of sulcus, or it can be a very open type of sulcus. So the 3 lines and 1 plane concept, there are line A, line B, line C, and a plane D. The line A is actually representing the superior margin of the duodenum. So during laparoscopic CBD exploration, always keep an eye on the superior surface of gallbladder. Then the line B represents the arc of incisure of the right posterior pedicle, and line C, it's the middle line between common hepatic duct and common bile duct. Always keep dissection just to the right of the line C, so as to avoid injury to the hepatic artery adjacent. And a plane D, it is actually the plane of the liver hilum or the hilar plate. So coming back to the anatomy of the biliary tract, the biliary tract starts from the hilum by the formation of right and left hepatic duct, which joins to form the common hepatic duct. Then the cystic duct joins, then it forms the common bile duct, and finally it joins the pancreatic duct, form the common channel, and enter into the second part of duodenum as the ampulla of Vetter. So these are the joining segments. The right side you have the segment 5 and 8 forming the anterior sector, the segment 5 and 6 and 7 forming the posterior sector, and they form the right hepatic duct. And on the left side you have segment 2, 3 and 4 ducts, which forms the left main duct. The caudate lobe duct may join the left duct, right duct, or it may join the hilum. So it is not very consistent. So the relationship of external hepatic biliary apparatus, the important structures are the portal vein and the hepatic artery. So if you see extrahepatic biliary tract, it consists of right and left hepatic duct, common hepatic duct, and common bile duct. The left hepatic duct is formed by the union of segment 2 and 3 ducts, and it may be joined by segment 4 duct. And the area where it joins the segment 2, 3 ducts varies. Depending upon that, the left, the B4 duct is divided by type 1 and type 2. I will come to it later. The right hepatic duct is formed by the union of right anterior and posterior sectoral duct. But this type of union is seen only in 57% of cases. And common hepatic duct starts from the confluence of the right and left hepatic duct up to the union of cystic duct, and CBD from the joining of cystic duct up to its joining with the main pancreatic duct, forming the ampulla of it. So the average length of average length of the left hepatic duct, average length of the left hepatic duct is 1.7 centimeter and diameter is around 3 millimeter. So the left hepatic duct is longer than the right hepatic duct. That is why when you do surgery for hilar cholangiocarcinoma, you are trying a right trisegmentectomy rather than a left trisegmentectomy, because we get a longer margin on the left side. And the diameter of the left duct is larger than the diameter of the right duct. And the union of right hepatic duct and left hepatic duct usually occurs at the right end of porta, in front of right portal vein. So the common hepatic duct is actually related to the right portal vein rather than the main portal vein. So that also helps in some cases of cholangiocarcinoma. When there is infiltration of the main hepatic duct, you may be able to do surgery by excising the involved segment and directly anastomosing the main portal vein to the left portal vein. So the common hepatic duct length varies depending upon the entry of cystic duct. It may range from 1 centimeter to 7.5 centimeter. Average diameter of common hepatic duct is 4 millimeter, and average the CPD having a length of 6 to 8 centimeters, and mean external diameter of CPD ranges depending upon which technique you use. The external diameter varies and internal diameter varies, whether you use ERCP, MRCP, or intraoperative measurement like that. So this is the relationship of extrahepatic biliary tree. When at the level of superior mesenteric portal vein confluence, to the left of CBD lies the gastroduodenal artery. When we go proximally towards the hilum, the CBD is related to the proper hepatic artery on the left side, portal vein on the posterior aspect. And when you go towards the cystic duct level, you will see the right hepatic artery on the right side, left hepatic artery on the other side. That is the area of common hepatic duct. So common bile duct is divided into traditionally into a supraduodenal, retroduodenal, then the retropancreatic portion, which is actually covered by pancreatic tissue completely in 83%, and a truly retropancreatic portion you see only in 17%, where there is no covering by the pancreatic tissue. And lastly is the intraduodenal portion, which actually forms a common channel with main pancreatic duct in 85%. The rest, it may join the duodenum separately, or it form a joining without a common channel. The very important anatomical area is the arterial supply of the biliary tract. So this is very important because injury to the bile duct, at what level it produces problem. You have to be very careful about handling the bile duct during surgery, because when you damage the blood supply to the bile duct, it invariably goes into stricture formation. So the knowledge of arterial supply is very important in the background of liver transplantation and in the background of vasculobiliary injury to assess or to predict the development of ischemic strictures. In contrast to liver, the biliary tract is almost exclusively supplied by arterial arteries. There is no supply like portal vein supplying the artery. This was the original teaching, and there are some differences in the current status of biliary tract supply. So the vascularization of extrahepatic biliary tract can be divided under retropancreatic CBD, supraduodenal CBD, which includes the common hepatic duct, then arterial supply of the hilar duct, and arterial supply of the intrahepatic bile duct. So if you see the blood supply of liver, you know, 75% of supply is by portal vein and 25% of supply is by the hepatic artery. But among the blood supply, the arterial blood supply, 75% goes and supply the intrahepatic biliary apparatus. So that is the basic division of the blood supply of liver. So blood supply of the biliary tract is almost entirely derived from celiac axis, that is the foregut artery, because it is developed from foregut. So this is the normal arterial pattern of extrahepatic biliary tree. You will have supply coming from below and supply coming from above. You have the ascending branches and descending branches. So the blood supply of extrahepatic biliary tract is mainly axial. So it's supplied by 6 to 8 arteries of 0.3 millimeter diameter, and it runs along the bile duct either as ascending or descending course, and it will anastomose with each other. And most prominent of these vessels are known as the 3 o'clock and 9 o'clock arteries. Then you have the right and left arch arteries, and then right and left marginal arteries. And 60% of these vessels are actually ascending from the lower vessels, like retroduodenal, retropancreatic vessels. 38% is descending from right hepatic artery or the cystic artery, and 2% is extraaxial. The vessels may join from the sides of bile duct. So there is a zone of overlap between the ascending and descending branch, usually at the inferior border of cystic duct. So if you know the Whipple's procedure, previously there was a tendency to keep the gallbladder and do anastomosis very low in the bile duct. So the incidence of stricture is higher because the blood supply of supraduodenal bile duct is poor if you ligate the gastroduodenal artery and the vessels supplying the bile duct from below. So it is advised to do the transection of bile duct above the level of cystic duct, because above the level of cystic duct, it is purely supplied by the vessels coming from the right hepatic artery down. So ascending branches usually arises from the posterior superior pancreatico-duodenal artery. It is known as the retroduodenal artery or artery of Edwards. Then you have the supraduodenal artery, you have gastroduodenal artery, and the retroportal artery. I will come to it later. And there are descending branches which comes from right hepatic artery, cystic artery, or sometimes from a replaced right hepatic artery. So retroportal artery is an important supply to the supraduodenal and retroduodenal bile duct. And it is seen in more than 90% cases, and it has a larger caliber than the marginal arteries which I was mentioning. And it usually arises from superior mesenteric artery in 58% and celiac axis in 42%. There are two patterns. One, type 1, the artery ascent on the posterior surface of portal vein and head of pancreas and may join the posterior superior pancreatico-duodenal artery. Type 2 artery, it's ascent on the posterior surface of supraduodenal bile duct and join the right hepatic artery. So what does it indicate? There is communication between vessels from below and vessels in the hilum. So whenever there is injury or ligation of the hepatic artery, the supply of the liver hilum, it may be maintained because of these communications. So there are three patterns which I already mentioned. One is the axial pattern, where with the right and left arches. You have ladder pattern, where the right and left arches are interconnected by branches, and there is a mixed pattern. So the 3 o'clock and 9 o'clock arteries are the marginal arteries. They are known as the paracholedochal artery, and they gives to a fine network of arteries on the surface of the CBD. It is known as the epicholedochal plexus. So paracholedochal arteries or the 3 o'clock and 9 o'clock artery give rise to epicholedochal plexus. From the epicholedochal plexus, vessels penetrate the wall of CBD and finally form subepithelial plexus and intramural plexus in the bile duct. So the blood supply of bile duct has three zones. One is the marginal artery zone, second is the epicholedochal plexus zone, and third is the subepithelial and intramural plexus zone. So the 3 o'clock artery usually arises from posterior superior pancreatico-duodenal artery or gastroduodenal artery and ends in the right hepatic artery. Whereas the 9 o'clock artery usually arises from posterior superior pancreatico-duodenal artery and ends in the cystic artery. So if you see the percentage wise, 3 o'clock artery is more constant in position. It's seen in around 95%, and 9 o'clock artery is seen in only 82.5%. So there are variable patterns of arteries described to supply the bile duct. So the cystic artery may give blood supply to the bile duct. So sometimes if you preserve the blood supply, the cystic artery, it can actually supply part of the bile duct. So next comes the blood supply of hilar plate ducts. So the hilar plexus in the liver hilum is actually formed from cystic artery branches, right hepatic branches, and left hepatic branches. So they form an artery known as the communicating arcade or transverse hilar marginal artery or a caudate arcade. And that is very important to supply the caudate lobe and hilar bile duct. And this actually represents the communication between the left-sided and right-sided system. So on the left side, the communicating arcade usually arises from segment 4 artery and sometimes from the left hepatic artery itself. But on the right side, it arises from right anterior superior artery or maybe arising from the right hepatic artery. So This transverse hilar artery actually represents an important communication between the left and right hepatic arterial system, and it preserves the blood supply to the liver hilum. So during the dissection of the liver hilum, if you use artery too much, if you ligate all the bleeding vessels in that vicinity, you are actually damaging this communication, and that can induce stricture later on. So this is the communicating arcade which I was mentioning. You can see the bile duct is retracted up, and the posterior view is coming there. You can see the arcade, or known as the transverse hilar artery. So this is the human dissection, where you can see the small vessels, but these vessels will enlarge at the time of need and supply the hilum. So that is why most of the patients tolerate ligation of the hepatic artery. But if you ligate the hepatic artery lower part, you may have to do cholecystectomy, but the biliary blood supply may be preserved. So the blood supply of intrahepatic bile duct is a very interesting topic. They're actually supplied by the peribiliary plexus, which is actually formed by the arteries accompanying the intrahepatic bile duct. But the peribiliary plexus has communication with the intrahepatic portal veins. So there is an injury to the CPD, may result in ischemic changes at the hilum. But the intrahepatic bile duct will not develop ischemic changes or strictures, because the intrahepatic bile duct may get supply from the portal vein. Though the oxygen supply is less, they may maintain the arterial and venous the flow to the intrahepatic biliary tree. So this intrahepatic peribiliary plexus continues with the plexus around the extrahepatic bile duct, and it represents an important communication between hepatic artery and gastroduodenal artery. So at the time of need, this arcade or this plexus also supplies the liver parenchyma and the intrahepatic artery. So this is the peribiliary plexus which I was mentioning. You can see the hepatic artery. There is connection between these branches with the portal venular branches. Then the next important thing is the venous drainage of bile duct. The veins draining the CPD are actually arranged in the form of two plexuses, which is very popularly known as the epicholedochal venous plexus described by Saint, and a paracholedochal venous plexus described by Petrin. So the epicholedochal plexus veins are less than 1 mm, and paracholedochal plexus, it forms two marginal veins, the 3 o'clock and 9 o'clock vein. And inferiorly, these veins and venous plexuses communicate with the veins, the gastric vein, posterior superior pancreatic duodenal vein, and the gastrocolic tract. So superiorly, the marginal vein enters the hepatic substance, or it may join the hilar venous plexus. The hilar venous plexus actually communicates with the veins of caudate lobe or segment 4 vein and the cystic vein. So these are all important communication when there is obstruction to the portal vein, like thrombosis of the portal vein. And the cystic vein always joined this 9 o'clock marginal vein, and this is also an important thing, because when you do cholecystectomy in patients with the portal vein thrombosis, you will see more collaterals around the cystic duct area or the neck of gallbladder rather than in the surface of gallbladder, because this is also an important communication between these branches. So this is in a nutshell the venous drainage of extrahepatic bile duct. This is the anterior view, and the right side is the posterior view. These veins actually communicate between the posterior superior pancreaticoduodenal vein, right gastric vein, and the pyloric vein, and finally it ends in the hilar venous plexus. So there is a similarity in the vascular pattern of bile duct. The venous plexus also will have the paracholedochal marginal vein, we have the epicholedochal plexus. They penetrate the bile duct and forms plexuses in the subepithelial area and the intramural area. These intramural and subepithelial venules dilate when there is obstruction to the flow of portal vein, and this is responsible for development of portal cavernomatous cholangiopathy, the otherwise known as the portal biliopathy changes. It has many components. The main component is dilatation of these veins, which produces stones. Then there is ischemic component, which produces strictures. But if there are no ischemia, there are no strictures, these changes are reversible by doing a portocaval shunt procedures. So there is another important thing described in literature. It is known as the accessory portal venous system. We know the portal venous system, which is formed by the union of iliac and jejunal trunk, joined by splenic vein, then from the superior mesenteric vein, then from the portal vein, and finally it divides at the hilum to form the right and left vein. But there is an accessory portal venous system. This is a parabiliary venous system. It is having an embryologic origin independent of portal venous system. And it runs along the common bile duct and hepatic artery. And it is composed of at least one big vein, which is compared to the marginal veins of velar, which I already mentioned, like the 9 o'clock and 3 o'clock. And it begins from the posterior superior pancreatico-duodenal vein and pyloric vein, and it divides to form a network in the hilar plate. And when where there is communication with the cystic vein and other veins. And the hilar venous plexus and branches to the veins of segments adjacent to the hilum, like caudate lobe or the segment of liver. So it represents a collateral channel for portal vein extending from the stomach, duodenum and pancreas and to the liver. So the flow of blood is always towards the liver through this channel, and it is the potential anastomosis between right and left liver. Because the portal vein occluded, the hilar portal vein is also occluded, this will represent the communicating channel between the right and left liver. And massive enlargement of this system is responsible for the portal cavernoma seen in patients with the portal vein thrombosis. So this is the formation of cavernoma. You see the thrombosis of the portal vein or superior mesenteric vein. The communicating vein starts enlarging, and that will actually takes blood from the mesenteric veins into the liver. That is the hepatopetal flow. So in each extrahepatic portal vein obstruction, the flow is always towards the liver hilum. So the second part of my topic is the plate system. The plate system is actually seen at the liver hilum. It consisting of bile duct and blood vessels surrounded by a sheath, which continues with the Glisson's capsule intrahepatically and hepatoduodenal ligament extrahepatically. But at the hilum, when you see the plate system, the portal vein is covered by a separate sheath of loose connective tissue, which can be easily separated. But the hepatic artery and bile duct, they are very closely packed. So when there is a hilar cholangiocarcinoma, the infiltration of the artery is faster than infiltration of the portal vein, because there is some separation of the portal vein from the hepatic artery and the bile duct area. So this is the plate system. You have three plates. One is the hilar plate, second is the cystic plate, and third is the umbilical plate. In addition to the artery vein, it also contains the bile duct, contains the nerve plexuses and a rich lymphatic network. So this is the intra-operative picture of these three plates. A good knowledge of this plate system is very important for performing safe and curative surgery of hilar cholangiocarcinoma, because we can do surgery of hilar cholangiocarcinoma, but it may end up in a margin positive resection. If you are not sure about the anatomy in that area, you may leave some bile duct which are actually infiltrated by the tumor. So the knowledge of plate system is very important when you plan surgery for a hilar cholangiocarcinoma. So this is the another view of the plate system. When you do surgery, especially in strictures or in hilar cholangiocarcinoma, the left duct is actually mobilized from the undersurface of the segment 4 or the lower part of segment 4. The Japanese call it as segment 4A, we call it as segment 4B. There is some difference in terminology which I understand. So you open that plate and then you can actually mobilize the left hepatic duct. So the hilar plate is bounded above by the segment 4, on the right by the rubeus sulcus, which I already mentioned, and the cystic plate. And on the left side, it actually continues with the umbilical plate. So the anterior Glisson sheath, that is the Glisson sheath to the right lobe, actually runs behind the cystic plate and the hilar plate, and the posterior Gleason sheath runs behind the rubeus. That is the normal pattern, but you can have the reverse pattern as well. The bile duct and blood vessels at the right side can be easily dissected because they are all away from the left-sided vessels. Without disturbing the hilar plate, we can actually take the Gleasonian pedicle to the right-sided system, like right anterior septal duct or right posterior septal duct. There are surface marking described, which I will discuss in the next topic on liver anatomy. So the next is the cystic plate. It is located in the gallbladder bed and is continuous with the capsule of segment 5 and 4B. So this is the area which are infiltrated in patients with the carcinoma gallbladder. The posterior posterior edge of the cystic plate lies above the canlis. Sorry for the auto correction. So it's a canlis line in the hilar area. In more than 83%, the posterior edge of the cystic plate is located on the right side of right portal vein branch. So we can do a safe dissection of the portal vein in that area. So the umbilical plate is located along the inferior edge of the ventral surface of umbilical fissure, and it contains the ducts and blood vessels supplying segment 2, 3, and 4. So it is continuous with the round ligament inferiorly. So the upper margin of the umbilical plate can be reached by incising the superior border of the round ligament. So when before the era of interventional radiologists, we were all doing a segment 3 bypass, popularly known as third segment bypass, by isolating this round ligament, or it's known as the round ligament approach. We will take the junction of the segment 2, 3 and 2, 3 duct and do a drainage of bile duct into the jejunum. So that is known as the segment 3 bypass. That is easy by incising the upper superior border of the round ligament. So the next thing is about the biliary confluence. You know, the biliary confluence is notorious for variation. It can be an intrahepatic confluence, or it can be the common type of extrahepatic confluence. Sometimes there will be an absence of the confluence because the right duct, left duct, and cystic duct all join together, and there is no common hepatic duct. So there are instances in which you won't see a common hepatic duct as well. So there are variations in the bile duct at the hilum. The normal right anterior septal duct and right posterior septal duct forming the right duct, and the left hepatic duct joining together to form the common hepatic duct is seen only in 57%. And there are so many variations described, and they are all named as type A abnormality, B, when there is a triple confluence where the right anterior, right posterior, and left joins to form a triple confluence is seen in around 12%. So 57% is the type A, 12% type B, but more common than type B is the type C1. That is the right posterior septal duct and the left duct joining the join to form the confluence, and the anterior septal joining separate into the common hepatic duct. So you may see the right anterior septal joining the left forming the confluence. That is the type C2. This is very it's not very common. And the last anomaly which is described is the type F anomaly. That is very important because the right posterior septal duct actually joins the cystic duct, and during cholecystectomy, if you don't identify this abnormality, invariably this patient will develop bile leak. So another interesting thing is about this biliary anatomy of segment 4, because the segment 4 bile duct joins to the left hepatic duct either in the vicinity of hilar confluence, that is known as the type 1 bile duct entry, that is seen in around 36%, and the most common is the type 2 where the B4 duct joins the left hepatic duct away from the confluence. But if you have a type 1 type of segment 4 anatomy as a part of surgery for hilar cholangiocarcinoma, you have to resect this segment along with caudate lobe, because when you discuss the surgical treatment, we'll all say about the caudate lobe resection. But if there is a type 1 type of B4 duct anomaly, you have to do resection of this particular segment. Otherwise, that will end up in a margin positive resection. So another interesting term is the George-Jaw crook. Actually, it is a normal entity because the right posterior sectoral duct actually forms a north turning around the right anterior portal vein. So if you do surgery on the right segment, if you are not sure about the anatomy, you will invariably injure this bile duct. So the north turning is a very common, it's the most common type of entry of the posterior sectoral duct, and that is very at very high risk for injury. So you have to transect, or you have to ligate the vein away from that confluence of right anterior and posterior portal vein. The left side is known as the south turning George-Jaw crook. That is, you can transect at any level because there is no risk of injury. Actually, George-Jaw is a Vietnamese surgeon. He described this entity in 50s. So next comes the hepatic artery anatomy. There are more than 10 hepatic artery variations described. Michaels has described a classification on hepatic artery, but this is not Michael's classification. It can be a replaced common hepatic. It can be a proximal bifurcation or a separate right and left hepatic from celiac, or it can be a replaced right hepatic from SMA, which is a common anomaly. Replaced right hepatic, replaced left hepatic from left gastric, and an accessory right hepatic from SMA. These are all common entity which we come across during hepatobiliary surgery and even during a pancreatic duodenectomy. A completely replaced right hepatic artery from SMA is seen in around 2 to 5% of individuals. Sometimes you may see a right hepatic artery crossing anterior to the CHT. In normal anatomy, the right hepatic artery usually courses posterior to the bile duct. It's seen around 70%, it is like that. But some cases it will course anterior to the bile duct, and during biliary surgery it is very important to make the anterior hepatic artery to the posterior artery. Otherwise you will injure this duct and may result in pseudoaneurysm of the right hepatic artery. And sometimes the right hepatic artery can go much behind the portal vein. So that is seen in around 7% of individuals. So this is another interesting thing known as the Moynihan's hump. Moynihan's hump is nothing but there is a caterpillar turn of the right hepatic artery. The important thing is at this level, there is a risk of damage to the hepatic artery. So you have to make sure that you have no damage. If the cystic artery is of very big size, which is more than the usual, you have to exclude a right hepatic artery. And if the cystic artery is a very small artery, again you have to exclude because that may not be the actual cystic artery, and there are risk of injury or pseudoaneurysm. The portal venous variation at the hilum is not very common, and it is described by two individuals. One is the Nakamura. He classified as type A, B, C, D, E. And the Cheng classified it as type 1, 2, 3, 4, and 5. 4 again is divided into two types. One is the classical 4 and 4 other type. There are other variations of portal vein described because the imaging of liver has improved because of the increased use of living donor liver transplantation. So when you do the portogram, you may see all these variations. So the type 4 and type 5, type 4 or the other variations are contraindications for doing a living donor liver donation. So there is injury to the donor liver. So type 1 is the classical right portal vein and left portal vein forming the confluence. Type 2 is a triple confluence. Type C is again the right anterior and left portal vein joints, and the right posterior is separate. Type 4 is the right anterior and right posterior joining as the separate one, but right anterior sectoral joins the left, not the confluence like the type 3, it actually joins the left. So only the right posterior sectoral vein is available for transplant. So these type 4 anomaly is actually a contraindication for doing living donation. So this is the anatomy of the left system. This is actually the blood supply and lymphatic drainage of the caudate lobe in relation to the left hepatic duct. I may discuss it later. And this is the anatomy of the left hepatic duct at the hilum. So at the umbilical fissure, you can see there is a J-shaped hook of the vessels, the arteries supplying the segment 4. It actually goes into the fissure and then supplies the segment 4 above and below, segment 4A and B, and then it divides into the right, the segment 2, 3 vessels. So the segment bile duct, the 2 and 3 joins to form actually the left hepatic duct, and the left segment 4 duct has many variations, and it may join at different locations, and depending upon that there are many variations, which I may discuss in the next topic. So lastly, we will discuss what is known as the lowering of hilar plate. I actually discussed this because when you want to mobilize the extrahepatic bile duct, if you want to get enough length of bile duct during biliary surgery, you will actually incise the border of the segment 4, which I was mentioning as the superior border of the hilar plate. So if you incise it, this is another view of the hilar plate and the incision line, which is described, and if you incise that area, you can actually mobilize. But during this incision, there is not much bleeding as well. But if you go too much into the posterior aspect, you are likely to damage the artery, which I was mentioning earlier. That may actually have problem with the anastomosing bile duct. So with that, I come to the end of my talk on surgical anatomy of biliary tract. I think there are few more things to be discussed, but I thought it is a very vast, it will become a very vast topic, so I omitted those. May discuss in the next topic. Thank you.
Simply brilliant, Prathapan. One of the most wonderful lectures I ever heard on anatomy of the biliary tree. Excellent indeed. Any questions and comments from the audience? Anyone to come up with a comment or a question?
I think during the general surgery posting, the exposure to the biliary tract, especially the hilum, is not that good. So majority of our members belong to the general surgery group. So they may have to see more dissections during their specialty postings. So that may be the reason for no questions.
No, but this is because it's very, very clear and much detailed. So for anybody to ask questions is very difficult actually. Dr. Rajan was watching for quite a while, and he didn't make a mention. And
he was my teacher, my mentor.
I was watching for almost more than an hour actually. And there's a good amount of audience in the Facebook group as well. It's a wonderful lecture, Prathapan. I think you're the right person to deal with surgical anatomy and GI tract, and you should continue to do this series, and you should get prepared for the next one. There are no any comments. There are some messages in the.
Somebody can read that.
Oh yeah, actually, yeah. The Pravesh Shukla was asking, can you elaborate little bit more about hilar plate lowering?
So I will try to make it the next lecture, because the anatomy, the liver hilum is more important when you do liver resections rather than doing the biliary surgery. So I was actually concentrating on the biliary surgical aspect rather than the liver surgery per se. So in the next lecture, I may include more details of liver hilum, the different type of approaches, the glycerol and pedicles and all. Take some time.
Certainly. Thanks, Pradhan. Thank you so much for this wonderful lecture, and we want to want to listen to you continuously. Thank you so much, and have a great Sunday. Thank you. Thanks, everyone.